So I'm Jesse McCarron, and this is the second year I've participated in this. We really appreciate all you coming. It's fun for us. It's nice to put faces with the names of people who are kind enough to send patients our way, and it's nice to be able to collaborate and take care of these patients together. So thank you all for being here. So disclosures, conflict of interest. These are mine, but none of them are relative to the talk or relevant to the talks that I'm doing today. I'm going to talk about overuse injuries of the elbow, and really I'm just going to talk about lateral epicondylitis and distal bicep ruptures. These two disease processes represent the vast majority of at least work-related elbow complaints that I see in the office. And I think they're also interesting because although they're really sort of number one and number two in terms of what I see in terms of workman's compensation claims, they also kind of sit at opposite ends of the spectrum in a lot of aspects of sort of the workup and treatment options available for them. You know, they're both repetitive overuse injuries that are, at the end of the day, the result of accumulated micro-trauma over time. So they share similarities in that respect, but you know, the lateral epicondylitis almost never has an identifiable trauma event related with it, and it rarely needs surgery. Distal bicep tendons are the exact opposite. There is always one acute event which leads the patient to present to your office, and essentially 100% of these people undergo surgery. So they're an interesting dichotomy in that respect. If you look at overuse injuries in general, for the state of Washington workman's compensation claims, elbow injuries account for about 3 out of every 1,000 workman's comp claims, which doesn't sound like a lot, but you know, if you go and you look at what that means over about an 8-year span of time, that's a lot, 30,000 claims for elbows over that 8-year period of time. So it definitely impacts the workforce in Washington State and Oregon as well. Of workman's compensation elbow claims, almost 50% of all those claims are for lateral epicondylitis, 1.2 out of the 3 for every 1,000. So lateral epicondylitis is definitely the overwhelming source of workman's compensation elbow symptoms that you're going to see in the office and that I see in the office. If you compare that to the general population, and this speaks to some of Ben's points about how much of this is really truly related to work and how much of it is just we get these things as we get older and we use our arms. The general population has about a 1 to 3% annual incidence of lateral epicondylitis. So there's 10 patients who are presenting to your office or at least having these symptoms out in the community for every one that's presenting to you for work. So this stuff isn't only related to return to work and workman's compensation claims. These people are also presenting to you on the sort of return to play side of our discussion today, and it impacts their quality of life for the things they're doing outside of work as well. Especially for lateral epicondylitis, a lot of this will go away if you ignore it for long enough and just sort of keep on doing your thing. But there is almost a 10% recurrence rate over 2 years if this goes untreated. And so there really is a role for proactively getting involved when these people come to your office with complaints. It's more helpful than just letting them know that it's painful, but it's not going to hurt you, and if you wait long enough, it'll go away. That may be true, but for a measurable portion of your patients, that's not quite the case. It is going to recur for them, and it is going to continue to be problematic. So we'll start with distal biceps injuries. This represents about 1.5 out of every 100,000 patients, so it's 100 times less common than lateral epicondylitis. But when it happens, it's dramatic. 100% of these people are going to present to your office. They're not just going to try and suck it up and expect this to go away on its own. Demographically, this is much, much more common in males than in females, and it typically occurs in people between the ages of 40 and 50. I can't think of any patient in my practice under the age of 40 who I've ever seen with this pathology. I have seen patients all the way up into their 70s with this, but a strong sort of large portion to the bell curve really sits in that 40 to 50-year-old range. Smoking may be a risk factor for this, in addition to just heavy repetitive use over time. Some studies suggest that, although that hasn't been definitively established. In terms of a little bit of the anatomy, this is helpful to know as you're working these patients up. The distal bicep inserts onto the bicipital tuberosity on the proximal aspect of the radius. And because it inserts right here, we all know that the bicep is a potent elbow flexor, and so it gives us this strength. But more importantly, actually, the distal bicep insertion gives us most of our supination strength, so that ability to roll the hand from palm down to palm up. And that's important because that's probably the single most relevant thing you can pick up on physical exam when someone presents to your office complaining of what may be a distal bicep injury. The reality is we have a lot of redundant muscles that provide us elbow flexion. And so even if your distal bicep is ruptured, a lot of people will still have almost perfectly preserved, isolated elbow flexion strength. But about 50% of all your force generating capacity for that ability to roll from palm down to palm up in that supination maneuver, 50% of that comes from your bicep. So if someone has a real distal bicep injury, that is always going to be profoundly limited, and that's the most sensitive thing you can pick up on exam. Some of the more superficial musculature and structures that are important to note, certainly for us as surgeons, we have to take note of the fact that you've got a number of important nerves, median and radial nerves, as well as more superficially some sensory nerves that supply most of the skin over the lateral aspect of the forearm that are all at play if these people will go to surgery. And you do have the brachial artery right here, which runs immediately adjacent to the bicep tendon where it inserts. So we have to manage those things at the time of surgery. More important when you're seeing someone first off in the office is actually this structure right here. So, even in this Netter's textbook, they don't name this structure, but this is the lacertus fibrosus. And this is important because this can trick you very often on your physical exam when you're seeing someone with a distal bicep injury in the office. We'll get to that a little bit more, but basically in this picture your distal bicep tendon is hidden right under here and it's diving deep into the forearm. This lacertus fibrosus is this thin, broad sheet of fascia that originates off the top surface of the bicep and invests along the superficial musculature of the flexor pronator mass on the medial side of the arm. And that does come into play when you're examining these people in the office. We'll go over that in a little bit. So mechanism of injury. Certainly you can get this, just a distal bicep rupture with just a heavy lift, but actually it's really rare for me to see someone in the office who presents complaining of this injury being sustained with a controlled lifting maneuver, even if it's an incredibly heavy lift. These are almost always associated with a sudden, unexpected eccentric load to the elbow. So I've seen a number of patients who have done it exactly like this. They're coming to a stoplight on their motorcycle, and they get a little off balance. The bike starts to go down, and as the bike's going down, they try and catch it, and they rupture their distal bicep. So you're almost always going to get a story of a sudden, unexpected loading event to the elbow, as the elbow is not coming into flexion, but rather as it's straightening, and then the patient will have a pop and immediate pain in the elbow, and that's how they'll present to the office. It's pretty rare that it occurs during some sort of a controlled maneuver. Most of them, when they present, if they're a couple of days out, are going to look like this. You can see that the bicep is clearly proximally migrated. The bicep muscle is a little bit higher up in the arm than it should be, and there's some pretty profound ecchymosis, which tends to center over the antecubital fossa and a little bit to the medial side of the elbow. However, you are definitely going to see some patients. You are definitely going to see some patients in the office who actually look like this, where you have minimal to no bruising. And maybe that bicep is proximally shortened a little bit, but maybe not. So distal bicep ruptures don't always have to look like this. Some of them are going to present this way. And one of the things that will sometimes stop a full rupture of the distal bicep tendon from retracting proximally are those lacertus fibrosis fibers that I referenced on that anatomy drawing, because those fibers, even if the distal bicep tendon itself is fully ruptured, those fibers, which are investing onto the medial side of the musculature on the forearm, will tether the distal bicep and stop it from retracting further proximally. So you don't necessarily need to see the bicep balled up further up their arm to have a suspicion for a diagnosis of a distal bicep rupture. On physical exam, when these people present, many of them will complain of, at least initially, pain in the antecubital fossa and the anterior aspect of the elbow. Although if they're even a couple of days out from injury, their pain at rest in the front of the elbow may be minimal to none. As I've already referenced, this key element of pain and or weakness with resisted supination, in my experience, is the single most effective physical exam tool that you can use to pick up these distal bicep ruptures. So the way I check this for my patients is I have them bend their elbow to 90 degrees, and then I place them palm down, and I basically hold their hand as if I was going to shake their hand. And I ask them, I say, I'm going to ask you to roll your hand from palm down to palm up, and I'm going to give you resistance. And so I basically, with my hand in that handshake position, prevent them from actively supinating their arm. And if that is either weak or painful for them, there is an exceedingly high likelihood that you're dealing with a distal biceps injury, regardless of what else your physical exam shows you. I think when I was in training and learning how to take care of this by reading textbooks and that sort of thing, the hook test is something that always comes up, and it's the idea over here that if you're examining someone in the office, you should be able to actually catch the distal bicep tendon in your finger and hook it to establish that the distal bicep is or is not intact distally. I can tell you now, more than 10 years into my practice, even for me now, the hook test is entirely unreliable. I would suggest that you actually not use it at all. And again, this comes back to this aspect of the lacertus fibrosis, because if the distal bicep tendon ruptures, but the lacertus fibrosis doesn't, then the bicep tendon will retract just a little bit proximal. It'll put tension on the lacertus fibrosis fibers, which are actually quite robust. And with your finger, you'll be able to hook the lacertus fibrosis fibers. And you'll be able to feel, oh, those are tough fibers, they're taut, they're attached to the distal, they're clearly attached to the bicep muscle belly, and you'll read that as an intact distal bicep on exam. And if that's what you're going by, there's a measurable number of patients that are going to come back a month later, still hurting, still weak. You'll eventually get the MRI, and you're going to discover that you missed a distal bicep rupture a month ago. It happened to me a number of times in my first year or two in practice, and I quit using the hook test. So you hear it referred to a lot. I find it's worthless. This also speaks to the fact that if someone has a high clinical suspicion for me for getting a distal bicep rupture, that is to say the mechanism is right, sudden eccentric load with a pop, pain in the anterior elbow associated with some weakness in supination, even if everything else on the exam looks fairly normal, there's no ecchymosis, the distal bicep isn't retracted proximally, this is one of the few disease processes where I will jump to an MRI very early on, because I do find that you can miss it easily. For imaging, I just talked about jumping to an MRI. Of course, you should always start with plain films. They are relatively cheap, they're relatively quick to get, and they are still the best way that you're going to get an assessment of the bony architecture, so you should absolutely start with those. Those will be normal, and then you'll move on to an MRI. This is a MRI of a healthy distal bicep insertion. So this is a cross-section of the forearm. This is the ulna. This is the proximal ulnar shaft right here. This is the proximal radial shaft, and this dark gray band is the distal bicep inserting onto the bicipital tuberosity, the proximal radius. And you can see here how contracting the bicep muscle is going to cause a rotational force on the radius, which is what drives the person from palm down to palm up. So this is why it's such a potent supinator. This is what it's going to look like if for some reason you're imaging a distal bicep and it looks healthy. And this is what it's going to look like if they've ruptured their bicep. So same structures, right? Only here's the bicep tendon. It's clearly detached from the bicipital tuberosity, and you have all this surrounding edema right here. This is also why it can take several days, or you may actually never see any bruising, even in the setting of a true distal bicep tear. There's going to be a lot of bleeding, but you can see most of it is buried pretty deep in the forearm, and it can take a lot of time for any bleeding that occurs down here to make its way all the way out to the skin and sort of show up over here. So it can take a week or more sometimes for bruising to show up if you ever even really see any. So in terms of the surgery, and I would point out, I see a ton of people in the office about 2 weeks after distal bicep ruptures who come in panicked because they were seen in the emergency room, and the provider they saw in the emergency room says, you ruptured your distal bicep. You have 2 weeks to get this fixed or you're done. And they come in and see me at like 13 days. And they're like, they practically have themselves NPO. They're ready to prep out their own skin. They're like, go doc, go. There's no question. If we see these earlier, the surgery is easier to fix these. But I have done several dozen of these a year out, 2 years out. I've done some of these 5 years out. These early referral is always nice, but you don't have to scare or panic your patient. This can be safely and effectively done by a competent surgeon a month, 2 months, even a couple of years out if need be. So you don't need to quite put that terror in them if you're seeing them in the office. Timely referral is nice, but we'll be able to get this fixed no matter when you send them our way. The surgery itself, despite the relative high density of neurovascular structures in this area, is actually incredibly consistent. It can be done through a fairly small incision and is really pretty darn slick. So this is sort of a typical exposure. This is someone's forearm laid out like this. So you're seeing the front of the elbow. This is the distal bicep right here. The tendon itself, aside from any thickening because of tendinosis and generalized disease, is kind of the thickness of about maybe your small finger. You can find it in the antecubital fossa. You pull it out here. And then what we do is we take some very high strength, non-resorbable suture material, and we put this locking stitch into the distal end of the tendon right here. And then we load the other end of these sutures. There are several different techniques, but this is the most commonly used technique, where you'll load the sutures. We call this a button, but it really almost looks like a large grain of wild rice. It's a very, very long, elongated ovoid structure, and it has eyelets in it. And what happens is you expose the radius where the bicep is supposed to insert, and you drill 2 holes through the bone. The first drill hole goes through and through and is a much smaller hole, and it makes a very small hole that you can't see on the back cortex of the radius here. And that back cortex hole is just large enough so that when you turn this button on end, you can slip it right through the hole. But of course, once it gets through the hole, it flips 90 degrees, and now it's too big to come back through the hole you just placed it through. Then on the front cortex, where the bicep is actually supposed to attach, you make a larger drill hole that's just large enough to accommodate the diameter of the bicep tendon itself. So once you have this button attached to the bicep, you slip this through both holes in the radius. It comes down onto the back side of the bone right here, and then you pull on the free ends of the suture that are exiting through the button, and that basically just pulls the tendon down into the hole, docks it there where it gets locked into place, and you can see you've got this little button flipped on the back cortex. Very, very reproducible, very reliable. The biggest risk with this, and it is exceedingly rare, but exceedingly devastating if it happens, one of the terminal motor branches of the radial nerve wraps around the proximal radius right about here. It's well under a centimeter adjacent to the drill hole you're making, depending on arm position and your trajectory of the drill you're using. Anatomic studies suggest that it can be as close as 2 to 3 or 5 millimeters from your drill hole. There's really no practical way with this surgical approach to directly expose and visualize that nerve. So there are case reports of injury to the radial nerve with drilling of this back drill hole. And if that occurs, that patient loses the ability to extend the wrist and extend the fingers. So it's functionally profoundly devastating for them. I have been lucky enough not to have that happen in my career. It is an exceedingly uncommon complication, but it has been reported in the literature, and every single patient that goes to surgery with me learns that this could happen to them because it's rare, but you have to let them know what they're buying into, and it's well worth the risk. But there are real complications that can be pretty profoundly devastating if the surgery is not performed properly. So in terms of the rehab for these patients, I put them in a splint for 1 week, and that's really just to sort of keep them a little bit more comfortable, let them feel like they're protected for a while. After that, we get them out of the splint in a week. Elbows do like to get stiff, and so getting them gently moving pretty quickly is helpful. Between 1 and 6 weeks, I just tell them they're allowed to gently use the arm for about a 1 pound weight limit at waist level, and they very quickly get back range of motion on their own. One of the biggest problems with these distal biceps repairs is that these people feel really good and really ready to go very quickly. For most people, by about 2, maybe 2.5 weeks out from surgery, they already feel like they are fully recovered. They've got full range of motion, they've got no pain, they can see that their bicep is back out to length and attached where it's supposed to be attached, and they're ready to start moving. And I need to slow these people down because, at 2, 3, 4 weeks out from surgery, the only thing that's holding this bicep in place is this strong suture material that I put in there and this metal button. And it's very strong, but it is certainly not strong enough to hold up to the heavy loading that would be seen with most of the manual laborers who sustain this injury. So they really get a preaching from me about the fact that they have to strictly be 1 pound of weight at most for the first 6 weeks after surgery. And again, speaking to the fact that the distal bicep is really important for rolling from palm down to palm up, until you educate your patients on this, most of them don't really think that this is a bicep activity, when in fact it's the most strenuous bicep activity they can do. So I have to warn them that you're not even allowed to use this arm for like turning and opening a heavy door or that sort of thing. That rolling palm up down to palm up is one of the most vigorous things you can do for your biceps, so you need to avoid that for a while too. Starting at 6 weeks, we start strengthening. These people rarely need any physical therapy. They just need to know how fast they're allowed to progress their activities. And basically, for the first month, I tell them you can double your weight every week. So it goes, 2 pounds on week 6, it goes 4 pounds on week 7, it goes 8 pounds on week 8, and then about 10 to 15 pounds. And then after that first month, I allow them to add about 10 pounds a week after that. And that gets them up really to full unrestricted activities by 12 weeks after surgery. Not 100% of my patients end up looking like our governor from California when we're done, but the outcomes really can be pretty remarkable from this surgery. I actually fixed a gentleman's bilateral distal bicep ruptures several years back, and 9 months after I fixed him, he actually won Oregon's Strongest Man competition. So, that's not speaking to my surgical abilities, but rather to the nature of this disease process and the efficacy of the surgical repair. These do really remarkably well when you get them. So they can be very satisfying for the whole treatment team and certainly for the patients, and these people get back to work really very quickly. So lateral epicondylitis. Let me just check my time here. Okay. So lateral epicondylitis is a little bit at the other end of the disease spectrum. In that it tends to drag itself out longer, and even though it's not as dramatic in terms of its initial presentation, these people are going to have a much tougher and often slower recovery process that may never be quite as perfect as either you would like or they would like, but they can certainly be improved upon dramatically beyond just sort of benign neglect. So lateral epicondylitis, or tennis elbow as it's often referred to, this is a process of inflammation and pain that affects the origin of the muscles that originate off the lateral aspect of the elbow, which are the extensors for the wrist and the fingers. Typically the lateral epicondylitis is reported as involving the extensor carpi radialis brevis, which is sort of the mid portion of that musculature off the lateral aspect of the elbow. But the reality is, for any given patient, it can involve any of these structures. Any of these extensor muscles off the lateral side of the elbow, from the ECRL all the way to the extensor carpi ulnaris, and exactly where they're reporting their pain can be variable depending on where the most dominant inflammation is here, but it can be really anywhere along that lateral ridge and the lateral epicondyle. The incidence is about 1 to 3% annually. Demographics, unlike the distal bicep, it is a pretty equitable distribution between males and females. Tends to skew a little bit younger in the patient demographic, 30s, 40-year-old, 50-year-olds, and it does more often affect the dominant arm. There are natural history studies of this that suggest if you just ignore it, the vast majority will go away after between 12 and 18 months. But there's also good evidence out there that shows if you choose to do something other than ignore it, if you treat it proactively, you're more likely to get it to resolve faster, and you're more likely to avoid recurrences over time. So, if someone presents to your office with these symptoms and they don't really seem particularly concerned or engaged, you can just let them sort of ride it out. But encouraging them to take some action on it, which is almost universally non-operative, should help them get better faster. The mechanism is just a repetitive wrist extension as well as pronation activities. So, if you're working the muscles and bringing that wrist and the fingers back, that's going to be aggravating these lateral structures. But also, repetitive wrist flexion, of course, is going to put stretch on those, and that can be a provocative issue as well. The pathoanatomy is microscopic tearing, or really tendinosis, which I think Ben did an excellent job of sort of delineating the difference between tendinitis and tendinosis when it comes to the hand and wrist stuff. And the tendinosis is really what you're looking at here. This is microscopic tearing of those tendons, and it can be associated with inflammation, but it's not really the same thing as a tendinitis. And I think that does speak in part to a comment I'll make later on about the relative benefit, or frankly lack thereof, of using steroids in these people. There can be an inflammatory component to this, but the inflammation is usually not the primary issue here. The main issue is a degenerative process involving the tendon, not the inflammatory process, which sometimes accompanies it. Pathohistology for this. Typically what you see if you were to get some biopsy tissue from this is what we call angiofibroblastic hyperplasia and disorganized collagen. So those are large words for an orthopedic surgeon. We like pictures a lot better. So normal, angiofibroblastic proliferation type stuff, right? So organized collagen fibers, very acellular. This is healthy tendon. But here you have all of these inflammatory cells. You can see the collagen that is here is very irregular and sort of wavy, and it doesn't project well in this better light, but there's a whole bunch of just disorganized collagen that's definitely not even tendon fiber here, associated with blood vessels, which are infiltrating into this area of disease to try and promote a remodeling response. So presentation for these people, they're going to come in reporting pain at the lateral epicondyle, usually increases with wrist hyperflexion and pronation as you put those on stretch. And they're going to be tender over the lateral epicondyle. Maybe a little bit paradoxically, even though we talk about this being a process that involves the origin of these tendons off the lateral epicondyle, most people aren't really tender right where that tendon comes off the bone. Most people are tender a little bit distal to that, really almost about a centimeter or so distal, kind of over where you would put your finger to palpate the radial head. They're much more commonly tender right in the sort of proximal portion of the muscle itself, as opposed to the tendon where it originates off the lateral epicondyle. They will often report a dull ache. It's often worse at night, and they often report intermittent, somewhat unpredictable, sharp stabbing pains. They go along and can be sort of almost random or ad hoc. They can do a certain wrist activity 10 times and it won't hurt them, and then the 11th time it gives them a sharp pain, and then it doesn't hurt them again for the rest of the day type of thing. So there's a dull ache, but also intermittent, what almost seem to be unpredictable mechanical sharp stabbing symptoms at the lateral aspect. They often report decreased grip strength, and they will often have exacerbation of their pain with resisted wrist extension, resisted finger extension, or with a forceful grip. And we kind of think about grip as being mostly the hand finger flexors, but the reality is to stop your wrist from dropping into full wrist flexion, a good forceful grip requires a balanced competition between both the extensors and the flexor musculature. So a forceful grip will really provoke lateral epicondylitis symptoms as well. X-rays, just like your distal bicep ruptures, are going to be negative, but you need to get them anyways to make sure that you don't miss something. First line for this disease process really should be physical therapy. And physical therapy really focuses on two things. What you're trying to do here with physical therapy is you're trying to give the body an opportunity to respond positively to proper mechanical stimulation. We know that throughout the musculoskeletal system, if you have disorganized scar and you supply a consistent and directed mechanical load, that tissue over time will reorganize into mechanically more competent and more effective load-bearing tissue. And the same thing is true here. So you may start out this disease process with this proliferative fibrovascular and inflammatory sort of degenerative process at the tendon, but the idea with physical therapy is to consistently expose these muscles and these tendons to mechanical loads that will allow the body to understand what the demands for these tissue are so that the body can undergo a proper sort of remodeling response. Somewhat counterintuitive to a lot of what we tell patients with our physical therapy, this is a physical therapy process that requires that you work through the pain. Sometimes, patients are instructed that if it hurts, don't do it. Exercise, do your physical therapy up to the point of discomfort and then stop. Unfortunately, this is not one of those ones. They need to be working through this. They're going to be loading this area. It is going to be uncomfortable. They need to do it anyways. But if they put in the work, the vast majority of people are going to get better with physical therapy. And the physical therapy really focuses on two things. It's stretching activities, and it's eccentric strengthening. We know from across various studies that look at sort of muscle and tendon conditioning and mechanical loads applied to the musculoskeletal body that actually the largest forces and stresses that are applied across muscle tendon units are applied not during the concentric or contracting phase of a muscle activity, but rather during the eccentric phase, during that phase where the muscle is actively contracting, but the muscle tendon unit is lengthening. That's what exposes all of our muscles and tendons to the largest mechanical loading forces, and those are the forces that you want to be exposing these tendinosis processes to at the lateral aspect of the elbow. These are called a flex bar. It's hard to see in these black and white images, but there are these very sort of heavy rubber bars that allow you to apply torsion, and they're very effective for doing eccentric loading, where you basically use the other hand to twist this rubber bar and give a good resistance activity, and then allow the patient to, in a controlled manner, bring the wrist from full extension into flexion. That's a good way to do eccentric mechanical strengthening, and it's something that can be easily taught in the office. The patient then takes that flex bar home and does it on their own. There are good studies, well designed, that show that both over the short term and the long term, physical therapy, if it's properly structured like this, does improve outcomes over just the watch and wait strategy for lateral epicondylitis. Forearm straps can be used. These are all reasonable adjuncts to try. They will all help some. None of them will help enough to really make you or the patient satisfied, but every little bit helps. So the forearm straps apply right over the sort of thickest part of the forearm here, and the idea is with these, they're basically glorified Velcro straps that have a little gel pad in here that you center right over the area of greatest soreness. And the idea is when you strap these down, that strap will catch some of the mechanical forces that run from the wrist to the elbow and sort of block some of that excessive load right at the lateral epicondyle. It can help symptoms, I've used these in the past myself. I can tell you they're annoying because if you strap them down tight, they can completely eliminate your pain. And then you find out 3 minutes later you've lost sensation in your hand and your fingers are going white. So you loosen it a little bit, and you get blood flow back and you get your sensation back, and then you realize that it just needs to be a little bit tighter to get rid of your pain, so you strap it down again, and you end up doing micro adjustments like every 2 or 3 minutes for the entire time you're wearing it. And it's a little bit annoying, but it does help. I do recommend it for a lot of patients, and what I tell them is don't wear it all the time, but if you have like a couple hours a week when you know you're going to be doing your heaviest demand labor, when you know that you're going to be aggravating the symptoms, but it's an activity you have to do anyways, that's a good couple hours a week to wear it during that time, and it'll help for that, and don't wear it the rest of the time. Ice is always good. It's not going to change the disease process, but may help with pain management. Non-steroidal anti-inflammatories, the very good question was asked earlier about whether or not these really work for these inflammatory processes. I don't know. I haven't seen these studies that say that this really definitively is going to help your patients. But it's reasonable to try. It's safe. It's got a low risk of complications. And if I am giving someone non-steroidal anti-inflammatories for this, I recommend that they really take them the way they should be taken, which means you don't take a dose, this morning because it hurts and tomorrow afternoon because it hurts, and sort of skip stuff in between. If people are going to try non-steroidal anti-inflammatories, they start it, they take it on a scheduled dose, just like you would take your antibiotics or any other, heart medications or anything like that. You take it on your scheduled dose for 3 or 5 days straight, and then you stop, so that non-steroidal anti-inflammatory is getting up to a therapeutic dose in your system, and you're keeping it there for several days to try and truly control this process. And then, of course, they need to stop at 3 to 5 days, because eventually this is going to take its toll on their kidneys and on their stomach lining. But that can be effective, and I think if you're going to try NSAIDs in your patients, that's the way you should be telling them to use it, at least for these types of processes. If they have failed time, rest, activity modification, and at least 6 weeks of that eccentric strengthening protocol for physical therapy, only at that point, if they come back and their symptoms still aren't improving, do I get an MRI for lateral epicondylitis. And most of the time in that setting, your MRI is still going to be stone cold normal. But in maybe 50% or so of those patients, you'll find something that looks kind of like this. So this is an AP, a coronal view of the forearm. You're looking at obviously the distal humerus, the ulna, the radius, and the radial head right here. So this is the lateral epicondyle, and this is this common extensor origin off the lateral epicondyle. And you can see the light gray, white changes in here, which are representative of that disease process going on within that tendon origin. The role for surgery, really 10% of your patients need surgery for this. The other 90% are going to get better with physical therapy, time, rest, activity modification. For the 10% of people that do need surgery, there are a number of different options you can pursue, and the literature would tell you that they're all going to give you equivalent outcomes. So there's obviously the most traditional open surgical approach, which frankly I think, at least in my practice here at Rebound, we use the least. I cannot remember the last time I did an open surgical procedure for lateral epicondylitis, and that's in part because we now have gotten much better at doing these arthroscopically, which is what we see in these pictures, and it is also because we have some other percutaneous techniques that I'll mention again in a second. So these are examples of what you can do arthroscopically. So these are pictures from an elbow scope, okay? And in this picture here, this is you're catching just a little bit of the radial head right here. This is the articular surface of the lateral distal humerus. So this is the deep capsular surface that originates off the lateral epicondyle here with, this is the deep surface of the capsule and the tendon. And we're using a shaver in here, and you can actually remove the capsule, and by removing the capsule, then you immediately get down onto these diseased tendon fibers. And you can debride the diseased tendon fibers and get down to something that looks like this. This is lateral distal humerus right here, radial head right here. So you're looking at the lateral capsule, And you can see the capsule has been resected. You can see the shaver right here. You can see some muscle belly here for the extensor carpi radialis longus, with the tendon itself having been mostly resected, and that removes that diseased tendon from that area. And the intention here is that you're basically you're creating a controlled injury, which the body should respond to with a constructive sort of healing and then recovery process. So you can do this arthroscopically. Other options are these percutaneous options, and this is actually what most of my patients end up getting more than anything else, if they end up being that 10% that does need a surgical intervention for this. I actually don't do these procedures if they come to me and they fail the physical therapy and the time and the rest and the activity modification. I will then typically send them along, at least for evaluation, by one of our physiatry colleagues in our group. They're our team members that have the greatest sort of skill set for these ultrasound-based office procedures. But basically, there are 3 variations on a percutaneous technique that you can use to address this disease process in the lateral extensor musculature. So this is an ultrasound of an elbow. This is the lateral epicondyle. You're catching just a little bit of a shadow of the radial head here, okay? So this stuff right here is all of that extensor musculature. And the stuff that's a little bit whiter here, that's normal tendon. The areas that are dark here, or hypoechogeneic, are the areas of diseased tendon that don't reflect the sound waves from the ultrasound back as well, and so it gives you a blank spot. And this right here is a needle that you're visualizing coming right into this disease area. And the ultrasound, you can see, gets you a very clear idea of where the area of disease is. And then there are a couple of techniques. The prolotherapy is actually a fairly generic term, with prolo meaning shortened for proliferative therapy. And it's generic because there's not one, it's basically an injection process where you take a needle and you inject material into the area of disease and tendinosis, but there's not one thing you inject. Everyone who does this has a slightly different sort of cocktail for their prolo injection. Some of them are actually diluted glucose-based solutions. There's sometimes a component of steroid or saline. So there are several different strategies here, but basically it's an ultrasound-guided injection into this area of fluid and chemicals that are designed to sort of trigger a more robust inflammatory response. These can be very effective, but these patients need to be warned. By definition, this is intended to provoke an inflammatory response. So after these patients get treatment with prolotherapy, their lateral epicondylitis symptoms are going to get worse for at least 4, if not 6 weeks after the treatment, before it starts to get better. And that's intentional, because you're basically trying to jumpstart that inflammatory healing process. There are also some proprietary techniques like 10X, which is basically where you use a larger needle under ultrasound, and you can go in there and mechanically break up this diseased tendon, which is can be basically emulsified and then sucked out through that same tube. And then there's percutaneous tenotomies, where you basically just go in with the sharp tip of a needle, and you intentionally just use that needle tip under ultrasound guidance to section some of this tendon material, again, sort of provoking a controlled injury, which hopefully will be followed by a controlled and organized healing response. Things that have fallen out of favor. For a long time, steroid injections were a mainstay of treating lateral epicondylitis. I think these are phasing out more and more. I actually refuse to give steroid injections for my lateral epicondylitis now, because in a best case scenario, the data now suggests that although these make people feel better temporarily, there is no benefit over absence of treatment or placebo injections by 6 and 12 months after surgery. So I know it's nothing but a Band-Aid that is really not going to help them over the long term, and that's the most optimistic assessment for steroid injections now. There are some studies that actually suggest people who receive steroid injections may actually be worse off than people who get no treatment by 12 months after surgery, after the injection. And certainly, people who get repeated steroid injections into this area can get the same complications we see with any steroids, which is thinning of the skin, atrophy of the underlying subcutaneous fat. Those people are really unhappy. So steroid injections have for a long time been very popular. I would encourage very judicious use of them, if at all, for this disease process now. So final slide, by way of summary. Distal biceps ruptures, lateral epicondylitis, these are going to be our two main things that at least present to me when it comes to workman's compensation injuries in the office. And they fall at very different ends of the spectrum in terms of acuity, identifiable traumatic event, and the need for surgery. The incidence for distal bicep ruptures is 100 times less than that for lateral epicondylitis, but because these patients are so limited and because the injury is so dramatic, you see them within higher frequency than the lateral epicondylitis, and it feels like that sort of mismatch in demographic distribution is maybe not as big as it is. Distal biceps, I get advanced imaging very early on because I know the physical exam can trick me. And these essentially universally require surgery, although you do have a very manageable time frame to get this done. Lateral epicondylitis is at the opposite end of the spectrum. No one gets advanced imaging from me with lateral epicondylitis until I think they've failed all non-surgical options, and I'm now talking about either me cutting on them or sending them to one of my colleagues who's going to stick them with a big sharp needle. So that's the only time I get advanced imaging for lateral epicondylitis. The vast majority of these can be treated with rehab, and only about 10% are really going to need anything as far as direct surgical intervention. So that's all I have for the talk. I appreciate everyone's time. We thank you all for coming. Any questions? Yeah?